Good morning, everybody. Topic for today for my talk is iron therapy and new approaches to treatment of anemia and cirrhosis. We have been on this series of anemia for the past 1 month, and a lot of individual anemias have been discussed by various speakers over the past month and their particular treatment modalities. So what I'll be discussing predominantly is what are the advances in iron therapy that have come across. We don't have a lot of significant advances in iron therapy specifically related to liver disease as such, but there are some advances which are based on the understanding of iron metabolism. So let's go through that. Now, Dr. Rakhi was the first one to have that lecture, so we have already gone through this, the causes of anemia and liver disease. Now, 75% of patients with chronic liver disease will have some form of anemia. Anemia can be usually blood loss anemia, which can be acute or chronic. It can be hemolytic, which can be acute or chronic. It can be bone marrow insufficiency because of various issues. It can be a micronutrient or vitamin deficiency. All right. Now, in that, what are the causes of anemia? So, previously it was always labeled that iron deficiency is one of the commonest causes of anemia in liver disease, but somewhere related to that, in a retrospective study from Austria, 78% of patients, retrospective, that is a chart based study, it was not a prospective study, 78% of patients had normocytic anemia based on the indices that you get from the report. 13% had microcytic and 9% had macrocytic. So predominantly it was normocytic anemia. However, GI bleed was the commonest cause of anemia. Acute GI bleed was the predominant cause. Chronic GI bleed would usually lead to iron deficiency. Iron deficiency anemia was seen in 9% of patients. Other vitamin deficiencies such as B12, folate was seen in 8%, and concomitant renal disease in patients with liver disease was seen in 5% of the population. Previously, in the chart-based study, which was from 2007, diagnostic workup was suboptimal in 53% of the patients. So, an appropriate diagnosis could not be made. But here on, from henceforth, because we have the lectures of anemia, a lot of workup is being done, and so if we have a retrospective chart review, we might be able to find more causes rather than this unnamed sector or subset of patients where the diagnosis could not have been made. Now, causes of iron deficiency anemia in chronic liver disease, it's always and always mostly blood loss. Blood loss can be acute or chronic. Chronic GI blood loss is labeled when there is a fall in hemoglobin of 2 gram over 6 months in the absence of overt GI bleed or non-steroidal anti-inflammatory drug use. So, chronic GI blood loss and acute GI blood loss. The sources of GI blood loss are gastroesophageal varices, which are present in around 50% of patients with cirrhosis, and variceal bleeds occurs in an annual rate of 5 to 15% depending on the risk of varices, whether they are high risk varices or low risk varices. Portal hypertensive gastropathy, a very common cause, which usually is also associated with GI varices. When you start eradicating, PHG can develop, which is controversial by some, but it is seen in a lot of patients, up to from 20 to 98%, and 60% of these patients exhibit symptoms related to chronic GI blood loss, which is very important, because when people undergo endoscopy, sometimes this is not attributed to them, but it is a slow fall of hemoglobin that comes from this portal hypertensive gastropathy, and then they do develop low iron stores, and when they get admitted, we are unsure of what's happening. GAVE, that is gastrointestinal vascular ectasia, which is a rare thing, and it does not cause acute GI blood loss. It usually causes chronic GI blood loss. And portal hypertensive enteropathy or colopathy, which are similar to portal hypertensive gastropathy. Now, just to recapitulate on the iron metabolism that Dr. Sarah discussed, we'll just go through this. So, RBCs account for nearly 84% of the total cells of the body. The total cells of the body. It's not just the thing of the blood. It's just 84% of the total cells, and they are produced at a rate of 200 billion per day. That is 2.4 million per second. This huge number requires a lot of iron, B12, folate, and protein. Now, the over evolution, what we have developed is that from bacteria to eukaryotes to now what mammals and to human beings, we have developed over to conserve iron. We do not lose iron except in sloughing of mucosa. We usually will not lose any iron. So all the dead cells of all the dead RBCs are recycled and all the iron is taken back, and the supply of 20 to 25 milligram of iron that is required by the body to produce this huge amount of cells is taken from the body with itself. The 1 to 2 milligram that is lost through suffering of mucosa and other mucosal tissues is what you need from your daily diet. Total body iron content in the male is 4 gram and 3 gram in the female. So RBCs contain the largest amount, and we continue to use our own stores for the production. So let's come on to a difference between, what's the difference between oral iron metabolism, oral iron absorption, and IV iron absorption. Now these were studies which were done on the basis when hepcidin was found. Hepcidin was looked at as an antimicrobial agent, but they found that it regulated iron more than what it did was an antimicrobial agent as such. So the maximum absorption capacity during oral iron treatment is estimated to be near 25 to 30 milligram. So whenever we give oral iron, you have to understand that the amount of elemental iron that will be absorbed will not be more than that. So giving extra doses in a day or higher doses in a day will not lead to extra absorption, because that is the capacity of the body. It will not absorb more. The iron carbohydrate complexes that are given through IV are usually rapidly taken up by the macrophages, and then the iron is released. So oral iron, when we take, it gets transferred, it gets goes into the intestinal cell, converts from ferric to ferrous form, then from the basolateral membrane, then it gets bound to transferrin, then it goes into the bone marrow where the RBCs take it up, and then it gets used. Whereas IV iron is directly taken up by the splenic macrophages, and then it is slowly released into the circulation. However, both require ferroportin to be present in the plasma so that it can be released. Now what is the antagonist of ferroportin? Is hepcidin. Ferroportin is the receptor of hepcidin. More the hepcidin, less will be the ferroportin, and more the iron deficiency, because it's a inversely linked product. So less will be the hepcidin and more will be the ferroportin. So more iron absorption, but oral has a limit of 25 to 30 milligram per day. Now what studies have found is that even slightly elevated or even normal hepcidin levels are sufficient to inhibit intestinal ferroportin, thus inhibiting iron absorption from the GI tract. So even in low grade inflammatory states like rheumatoid arthritis or chronic kidney disease or autoimmune liver disease or autoimmune GI disease, where there is a low grade inflammatory state, the hepcidin levels may be normal, they may not be elevated, but they are enough to inhibit your iron absorption orally. So that is when you do not get any response to oral iron, and the question is arising that what is the cause of this anemia. However, macrophage ferroportin, whose expression is much higher than at the intestinal level, requires much more elevated levels and to be substantially suppressed. So that is why in patients with chronic inflammatory disorders or chronic diseases where there is ongoing inflammation, IV iron is much better than giving oral iron. I'll come to the discussion about this later when we discuss oral versus IV. So pharmacological iron, what we give is in either ferrous form or ferric form, usually in the ferrous form. Now it is absorbed in the same way as iron which is present in plant foods. The absorption of iron which is present in meat, which is in the form of heme, which is there in the body, is in a different pathway, and the exact pathway has not been elucidated. However, it usually does not require the DMT1 pathway and is absorbed through different ways, and the absorption is better even in chronic inflammatory states. So heme iron which is there is absorbed through different pathway rather than the ferrous, the routine pharmacological. So companies came up with heme iron polypeptide, which required lower doses of lower amounts of iron, but the costs were too prohibitive and are still very expensive. So what happened after hepcidin got discovered? So when hepcidin got discovered, people started studying what happens to iron absorption and iron levels with hepcidin. So this was a study done in Switzerland in the University of Zurich by Dr. Zimmermann and his group. So what they took was, these are healthy males which were given a single dose of iron, as you can see in the graph. Okay, yes, you can see. So they were given oral iron. So the oral absorbed iron, when they are given a 60 milligram dose, the iron absorption peaks and then it starts falling. And what happens to hepcidin is, it's slow at the start and then it starts increasing. So hepcidin responds to iron loading. So as soon as iron starts increasing in the bloodstream, hepcidin levels start rising, because that is the way the body ensures that excessive iron is not absorbed. So then they did another study. What they did was that they chose iron depleted young women, that is those who did not have anemia but had low iron stores based on ferritin values and transferrin saturation, but they did not have anemia. And they did 3 studies. One was a single dose of oral iron followed by 2 doses. One was 2 consecutive doses twice a day, and once a day, sorry, and one was consecutive or twice daily dosing followed by levels. So what they found, I have chosen just one graph out of this. So when you see this graph, so day 2, when they gave iron, the hepcidin levels are already low, all right. In the evening, the hepcidin level rises as expected from the previous study. On day 3, the hepcidin levels are slightly elevated already, and they continue to be. So the iron bioavailability on day 2, that is the first day of iron dose, is high, between 20 to 35%, and then it decreases. So even in iron depleted people, hepcidin iron availability decreased when you gave concomitant iron, because the hepcidin values kept on rising. So naturally, because this was not anemic patients, they did another study. This was a randomized controlled trial where they chose consecutive day dosing versus alternate day dosing in patients with iron deficiency. However, the caveat in this trial is that it was a small number, plus it was also that they were not significantly anemic. They did not have moderate anemia. They had mild anemia. Hemoglobin be around 10 to 12 gram percent. So what you see in this graph, what you see in this table, is that the fractional iron absorption over all 14 doses, consecutive day dosing versus alternate day dosing, the fractional iron absorption was more. The total iron absorption was also more, significantly more. And when you see the graphs, you can see that once day versus twice day, the fractional iron absorption goes on decreasing, and here the hepcidin value goes on increasing, but it comes down when you give alternate day to normal values, whereas when you do twice daily dosing, it does not come back to normal values. So in this study, they showed that patients with mild iron deficiency, if you are going to treat, do not give them alternate day, do not give them daily iron, give them alternate day iron. All right. Now the next thing was, what about if you give the whole dose together, not split dosing? That was the next part of that study, that instead of giving one capsule of iron twice a day, why don't you give the 2 capsules of iron once a day and see what happens to the iron absorption? So again they did it separate, and this was a crossover study, and what they found was, there was a significant, as you see 200 mg, the fractional iron absorption with a double dose of iron given one day in the morning is lower, and the hepcidin and the total, however the total iron absorption is slightly higher, because obviously you are giving more dose, but the fractional iron absorption is slightly lower. Even in this study, these were not significantly anemic women. They were just iron deficient women with anemia, not significant anemia. So this was one of the limitations of the study. So what we see is that even low dose iron given alternate day in patients with mild anemia can improve is related to improved outcomes, does not compromise the efficacy of treatment, and there were no significant differences in the side effects. Now, one study which I have not quoted here is the study done by this same group in African infants who have started weaning at the age of 6 months, and because of high prevalence of iron deficiency because of worms and food scarcity, they used iron supplements in micronutrient powder which was given to infants. And what they found was that when you give iron supplementation to these infants, they have increased amount of diarrhea. So we might say that, oh, so it's the iron which is causing the diarrhea. But interestingly, they also did a microbiome study. And what they found was there was change in the microbiome in Kenyan infants around 6 months of age who received iron, that there was alteration in the number and increased number of Enterobacteriaceae, which are pathogenic, Clostridium perfringens, and Lactobacillus also. So this probably led to increased amount of diarrhea in those Kenyan infants. Whether this is applicable to adults, we do not know. Even fecal calprotectin levels they did, which was significantly elevated in those receiving iron versus those not receiving iron. They did this fecal calprotectin levels in the alternate day and daily dosing in the previous study which I had shown. They did not find it to be significantly different. However, these are normal people with a good functioning intestine. We do not have any data regarding adults as such regarding the microbiome, or even in patients with chronic liver disease, where the role of microbiome is emerging and is significant because a lot of the infections such as even SBP and sepsis is caused by the microbiome. Now, to this part, thankfully we have an Indian study done from SGPGI, and they did a randomized control trial of twice daily versus alternate daily iron therapy in treatment of iron deficiency anemia. Now, this was like 60 milligram of iron once a day, alternate day, or 60 milligram of iron twice a day, and they saw the outcomes at 6 weeks, 3 weeks and 6 weeks. What was the primary outcome was rise in hemoglobin by 2 gram% at 3 weeks. So they found that twice daily dosing did not led to improved responses, and there was better outcome at 3 weeks and 6 weeks. There was no significant difference in the side effect profile except for nausea. They even did plasma hepcidin levels, and they were not significantly different. So what was the good point about this study was that they took a whole gamut of anemia from severe anemia, that's hemoglobin less than 8 grams, to mild anemia, whereas the previous studies done in Switzerland were only of mild anemia. So looking at the whole caveat and looking at the whole discussion from 2007 or when the studies were started, what we understand is that in people with mild anemia, hepcidin levels rise faster because they are normal, obviously because of iron loading, and they would be better off getting alternate day dosing. Whereas those with moderate to severe anemia, because their iron stores are so low that they will not have a significant rise in hepcidin, it is better that we can give them twice a day daily dosing. But we always have to remember that the amount of iron that can be absorbed per day would be around 25 to 30 milligram of elemental iron, and you have to calculate this amount of iron that you are giving based on that rather than just tedious dosing. Now, which iron salt do you use? So commonly what I have seen being used is Orofer XT, that is ferrous ascorbate. So this is ferrous ascorbate is not here, but ferrous ascorbate usually also provides 35% of elemental iron. Because it is an ascorbate salt, ascorbic acid is involved, it is absorbed better. So predominantly everybody has been using ferrous sulfate. Now it has changed over to ferrous fumarate. Ferrous sulfate is hardly even available in India now. If you try and find out ferrous sulfate, you will not get ferrous sulfate easily. Ferrous fumarate and ferrous ascorbate are easily available. So classic schedule was 100 to 200 milligrams per day, because it gives 30% of the elemental iron. So of 100 you are giving 30 milligram and you are trying to supplement it. So if the deficiency is more, the body will try and absorb more. So you get twice a day. So 100, 100, 200, that's 60 milligram, of which the body, if it absorbs 30%, so it will be at least around 60, so it will be around at least 10 milligrams of iron will be absorbed. Now, depending on this, as you can see, the usual amount is 20 to 30% and does not cross 50% or more. So does not make any difference which salt you use. Does it make any difference pharmacoeconomically? Yes. So this was a study done in Pune by gynecology department, thankfully, where they found that where they tested ferrous ascorbate, that's orofer, ferrous fumarate, that's otrin, and iron polymaltose complex. You can add any other number of drugs also by whatever is sold by perpetuated by the company representatives, because they just try newer ways to sell their salts. So what they found was that ferrous ascorbate had the highest rise in HP over 30 days, all right, but pharmacoeconomically ferrous fumarate made the best impact, all right. So just to give you an example, so cost effectiveness ratio, so 281 rupees for iron polymaltose complex, which does not even get absorbed properly. Then ferrous fumarate is only 60 rupees and ferrous ascorbate was 184 rupees. So to give you an example, I have written down the cost of the drugs. Orofer XT that is commonly used, 10 tablet strip costs 130 rupees. So 30 days, if you are giving twice a day for 30 days, so it will be around 6 strips. All right, so it will be something around 1000 rupees. Otrin 30 capsules cost only 120 rupees. So this would be like 240 rupees for a month. Ferritop S, that is sustained release, which should not be there. This is ferrous sulfate, which I found online by another company. So this sustained release, which is not effective, which is not good, but it is ferrous sulfate. 150 capsules cost just 350 rupees. So it's very, 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 very cheap. So you could use either of these two salts, and cost effectiveness. You are not gaining extra by giving any other expensive salt. What we are paying, patients are paying out of pocket. So try and reduce the out of pocket expenditure. And as we know, any illness causes significant drain on your social and economic expenses. It's not that there is a lot of difference between the side effect profile either, because you are not using heme iron. So let's compare IV versus oral. So this in CKD patients, this was a trial done comparing liposomal iron, oral liposomal iron versus IV iron. So the short-term therapy with IV iron produced a more rapid hemoglobin response compared with liposomal iron, although the final increase was similar. However, because at a certain time point when all the iron supplementation was stopped, the oral iron was stopped after 2 months, again there was a fall in iron stores. However, this was not seen in IV iron. All right. So the important part is that we are not correcting just the anemia, we have to correct the iron stores. So whenever we prescribe iron for an anemic patient, you have to prescribe it orally, where you have to prescribe it for a longer term, and whenever we are prescribing IV iron for an anemic patient, you have to calculate the stores and correct those stores also, because the body will utilize that iron and slowly all the stores will not get replenished, and the person will land up again into the same trouble of having anemia and depleted iron stores when they came to you. So IV iron extremely safe, and as we see, iron sucrose has only an adverse effect profile of 0.6 cases per million doses compared to a high molecular weight dextran, which was previously a lot of causing culprit of allergic reactions and even death. So IV iron is very safe. The only issue is that now IV iron is slightly costly, but otherwise it is very safe. So IV iron preparations that are available in India predominantly are iron sucrose and iron carboxymaltose. So iron sucrose is very cheap, but it has to be given repeatedly. All right, it has to be given slowly, Iron carboxymaltose is slightly expensive. However, you can completely correct the iron stores with the help of 1 to 2 doses of iron carboxymaltose, and it is safer to give, faster to give, and it can be given as a slow IV push. Now, what are the indications of IV iron? As like I was discussing previously when I said we'll come back to this later, any chronic inflammatory disease where there is anemia, you should try and supplement IV iron rather than oral iron, because you are unnecessarily subjecting the patient to complications of oral iron, that side effect profile, plus the iron will not probably get absorbed because the hepcidin is going to reduce the amount of iron that is going to get absorbed, because there is a chronic inflammatory state and hepcidin is an acute inflammatory response protein. So, severe iron deficiency anemia, you can give it, you can correct the iron stores. End stage chronic disease, which is where it is standard now, inflammatory bowel disorders, one, because you correct the iron stores, and second, you avoid the change in the microbiota, and plus you avoid the side effects of unabsorbed oral iron, which creates problems in the GI tract. Heart failure, where it has been shown that small doses of IV iron improve the outcomes in patients with chronic heart failure. Why? Because of similar reasons, that chronic heart failure is a low grade inflammatory response, there is anemia, there is decreased absorption, and there is increased fatigue and dyspnea. So how much to give? So how much to give? It's not out of the blue. Use the Ganzoni formula, which has been there since 1960. Simple is, total iron dose is body weight into that is body weight into the difference in the HB into 2.4 plus 500 milligram for adults. Very simple, body weight, say 50, 60, difference in the iron into 2.4 plus 500 milligrams. So usually when you have moderate anemia, this will be the amount of iron that's required if you have severe and if it's critical. So use this to correct the iron dose, correct the iron stores rather than just correct the anemia. Now, what can we do here? Proposed study topics which I looked at is that one, we can see the levels of hepcidin what we have in patients with liver disease when we give alternate day dosing as compared to daily day dosing. Whether there is any rise or not. Why? Because hepcidin is made in the liver, and in liver disease hepcidin levels are low. However, in some disease states such as autoimmune liver disease, they might be elevated and there might be a differential response. So we should definitely get checked. Second, outcomes including incidence of sepsis and SBP on alternate versus daily dosing. Why? Because we are changing the microbiota. There is more iron which when you give orally, which goes into the gut, and the microorganisms use that iron for proliferation. So is there any difference in the number of SBP or sepsis episodes? Second, third would be comparison of oral iron versus IV iron in maintaining HB in patients of liver disease with respect to transfusion requirement, iron stores, and cost effectiveness over a period of 6 months or 1 year when they are regularly coming for follow-up. The last one, what I thought was changes in the microbiome after oral iron supplementation and the long-term impact on outcomes. That's all. Thank you.